disorders also, because a lot of times, I think there's a few issues. Boredom can often lead to increased substance use. So what we're seeing even in the hospital setting is that more people are using both alcohol and sometimes drugs. Sometimes related to boredom, sometimes related to anxiety, or they're just not able to actually get what they usually get and they're trying new things. And that fits under marijuana, that can fit under the alcohol use disorders. We've seen some increased use of K2 in this area. And so these substance-related disorders can actually really create confusion for people during this time also. Cognitive and developmental disorders, I'm not going to spend a lot of time on now, but for students, we could even be talking about kind of the ADD, the ADHD, could be talking about dyslexia or some of those disorders as well. Again, identifying them and learning the strategies to help manage them are equally as important. And of course, there are some physical disorders that fit under this umbrella also. So if we talk about kind of components of mental health, what are those things that really are contributing to one's mental health? Then we have to look at a couple of things. One is our individual biology, and this is where we're talking about genetics. So we'll see a couple of different things. We'll see people that have a pretty strong history of psychiatric illness in their family. That could be depression, that could be anxiety, that could be risk of suicide, a lot of these things. And we have to actually consider those concepts when we are talking about people's risk, when we're talking about what we think is the most likely diagnosis. It doesn't necessarily mean that if your first degree family member had bipolar disorder, that you're going to have bipolar disorder. But what it means is that we have to understand this spectrum of disease to understand that there are genetic components that predispose us to certain mental health disorders if there are those or others in our family. Behavior is a component of that mental health too. We talked a little bit about substance use in the last slide. And what we know is that if I take two people that even have anxiety, but one of those kind of patients is drinking at night to help them get to sleep and to help manage that anxiety, they're not, these two people now are not the same anymore. Their treatments are going to be different. Because for one, we still have to figure out how to treat the anxiety, which actually is true in both of them. But now we have to address the drinking, because while people may think that that helps with anxiety, the long-term repercussions of that are really multifactorial. And so that has to be addressed. Social environment. We talked about kind of racial disparities, and we are seeing an increase in anxiety. We are seeing people come in to the hospital even because of the amount of stress that current events, we talked about the racial injustices combined with COVID, that's causing a lot of stress. And we're going to talk about things that we can do to help alleviate that. We all want to, we're all kind of here because we enjoy, might not be the right word, but we're academics at heart, and we want to be able to solve problems. But sometimes we have to also understand what our own boundaries are and understand that sometimes turning off the television, turning off the news is as important as being aware of what's happening at a single moment. Access to care. You guys are going to hear from JHSAP and what's available to you as students, but it's also important to really remember that not everybody has that access. Not everybody is willing to seek help, and that creates a lot of barriers to getting better also. We can talk a little bit about the public and institutional policies and how those are affecting our mental health, and then the interventions that are available as well. This is a relatively old slide now. It's from 2018. But what I want to highlight on this slide is that if you go all the way down to the bottom, they're neuropsychiatric disease. So they do tend to lump neurological and psychiatric diseases, so the brain disorders together a lot of times. But what you'll see is that if you were to look at the U.S. burden of diseases, we've got, we've got cardiovascular disease, we have respiratory diseases, we have cancers here. But what we're seeing is that if we really see what's causing the U.S. the most money in terms of illness, in terms of medical illness, what we're seeing down here is that these neuropsychiatric disorders are causing a lot of dollars as well. And that's from many different ways. Part of it is from loss of revenue. people can't work if they're depressed. They can't necessarily, they utilize the emergency room a lot of times if they're depressed. So the things that it's causing in either U.S. burden of the disease or the lost wages or access to care, all of those things kind of accumulate into seeing that really mental health disorders are causing a lot of monetary repercussions as well. So let's talk about depression for a second. When we talk about depression, really we talk about the bread and butter of how do we make a diagnosis. And in medical school, we have kind of a term that we use, but when you break it down, it literally is changes in sleep. And please note that I'm saying changes in sleep because sleep can go up for a lot of people, right? Sometimes there's people that will sleep all day and just won't have that motivation to get out of bed and they're just there. But sometimes that can be lack of sleep. They can't go to sleep. They can't get things off of their mind. And what both of those kind of changes can be pathognomonic for depression. Interest. Has your interest in things changed? So if you're someone that loves to play tennis, is that not exciting to you anymore? If you're someone that loves to connect with family members, now maybe that's been taken away with the pandemic, but are you not getting the same desire to do so by Zoom or remotely? If you're someone who really enjoys getting out and exercising, have you lost focus for that? So that's part of it. After that comes guilt. And guilt can be a lot of different things. It can be really just what we call ruminating or fixating on certain concepts. So, oh man, I shouldn't have said that. I shouldn't have said that to my, classmate. And you just think about that over and over again about how wrong you were, or I'm just a horrible mom, I'm a horrible wife, I'm a horrible son or daughter, or whatever those things are, because you're magnifying certain things that are happening in your life right now, and you really do focus on that over other things. Loss of energy. That again is I don't want to get off the couch. I don't want to go out with you guys walking. I just don't have any desire to do those things. And that can couple with decreased concentration. So for students, a lot of times we will see that they can't focus on their reading. They have to go back and read the same page over and over again. When they're in class or trying to listen to lectures, their mind's just wandering off to other areas. So you really can't focus. Changes in appetite. So I'll highlight this just like I did sleep. Changes in appetite. Appetite can go up for some people, especially some people will say that they have increased interest in carbs. They're eating sweets all the time. So their appetite changes. But for others, that's, I don't eat. I don't have a desire to eat, or even if I do eat, the food doesn't taste good. So we're looking for those changes in appetite as well. Psychomotor changes is a big one. It sounds like, kind of a major term, but what we're looking at literally is changes in how you're moving. Can you really not even get up out of the chair? Are you standing still and kind of standing in the same spot? Are you staring? Or can you not settle? Can you not sit still? Are you up and down and moving around and going from here to there just because you can't slow your mind and your body enough to kind of be still for a second? So that can go both ways as well. And then the last one I'll highlight is thoughts of suicide, because that's really important. A lot of times in my field, I will ask people, point blank, are you having any thoughts about hurting yourself? And some people will respond to that, well, why would you ask me that? Or I wasn't thinking about it until you asked. But what the studies are showing is that we need to ask and we need to take those things seriously. And so there's a big push. I don't think I have this slide in this talk, but there's a big push towards trying to find ways to decrease suicide rates in the United States. And if we look at, kind of death from cancers, if we look at death from cardiovascular disease, all of those kind of slopes are starting to go down. We have really good cancer treatments. We have really good high blood pressure medication now. So those things we're making a mark on. Unfortunately, suicide's not the same. And so there's a lot of even studies that are going out now to try to figure out how we can rescue people that are feeling that desperate. Now, if you're looking at this slide, you might say, oh man, well, I didn't get out of bed this weekend at all. I just couldn't move. Or you might say, well, I think it's the pandemic, but I haven't been exercising as much as I used to. I just don't like it anymore. And listen, everyone's allowed to have some of these things some of the time. The reason that we diagnose depression is when you have, and we don't have to go into the specific numbers, but you have a large chunk of these that would be true at the same time and for an extended period of time. Historically, 2 weeks is what we'd be looking for. So everyone's allowed to have a bad day, and that's what you need to remember. That's okay, but when you're meeting most of these criteria for extended periods of time, meaning you're not able to pull yourself out of that, you're not able to feel better, you're not able to kind of motivate to do things, you're missing class, that's when we want to talk about whether or not you're having a depressive episode. And I like to highlight this picture here, Blue Monday by Annie Lee. And this is important to just look at because this is, it's a Blue Monday, right? So we all can have those days where it's like, oh my goodness, either because you had a great weekend or because you have a test today, or there's many reasons why you might wake up feeling like this. But it's more than just a bad day. And that's what we want to highlight and really get people to understand is that this feeling on Monday is where a lot of us are on Mondays. But if that feeling is the Monday, Tuesday, Wednesday, Thursday, on and on and on feeling, that's when we want to start talking about some other things too. So then let's talk about diversity for a second. If we look at, again, kind of an outdated slide, but the numbers will shift appropriately, what we're seeing is that in general, the African-American population is making up about 12, 13% of US race. And if we take that information, then what we're seeing is that about 16% of those people, 16% of Blacks or African Americans in the nation will have a diagnosable mental illness if you look back over the prior year. And the reason that's important is because that's about 7 million people. And I can guarantee you that 7 million people are not in treatment and not getting those diagnoses right now. So one of the things we want to talk about is why that's not happening. What's different? What's different about this population where they're not getting or necessarily seeking the help that they need? So what we know is in general, about 25% of Americans will have something that meets diagnostic criteria for mental health illness. And that can be many different things, depression, specific phobia. I mean, there's a lot of things that kind of will be under that umbrella. But in general, we're seeing that really the minority populations are not seeking help in the same numbers. So this, again, is data that was collected over a 3-year period. And for students, I like to at least show a little bit of data. It's not my own personal work, but what we're seeing here is that the rates, a lot of times, of depression in the African-American community are equivalent to or exceeding those in non-Hispanic, whites, and even the Hispanic population. And so the question, the reason I like to highlight this is because, again, it impresses upon us the importance of getting the right diagnosis, because there's often treatment. But if we don't get that diagnosis, if we don't see someone, then we're not able to move forward with treatment. The other reason that this is important is because people may be sitting and wondering, is this normal? Is this okay? Is this just grief? Is this just kind of a bad mood? And talking through that is important because even if it is just a bad mood or grief, there are still treatments to help you manage that also. For Diversity Week, I also want to just highlight quickly what happens in females, what happens in women. And the reason that I wanted to highlight that is because women in general, if we talk about depression, are 2 to 3 times more likely to experience a major depressive episode compared to men over the course of their lifetime. And so typically this will happen around ages 25 to 44. The reason we have to highlight that is because I'm guessing that a lot of people that are with us today and a lot of your friends are close to kind of that age range. And that's a tough place to be because a lot of times you are either finishing up school, working at grad school, starting a family if that's your choice. You're doing other things. And so it's really hard sometimes to understand, is this depression? Is this kind of just a normal reaction to the stressors that I have in my life? And so it's important to try to also sort that out. In addition, once you're diagnosed with depression, women are more likely to have ongoing episodes over their lifetime. So it's not just about getting that diagnosis. And remember, even with treatment, it's not curative. We're treating episodes, trying to prevent episodes with medication, but it's not necessarily curative. And so in that space, women are more likely to have these breakthrough depressive episodes as well. And there's a higher risk of substance use disorders in this cohort, in that population of women. And I also highlight the superwoman syndrome. So I actually had identified Michelle Obama as one of the superwomen. And for a lot of people, when she was doing her book tour and everything, this is what we identified with, was that, you know, at a certain age or at a certain phase, you're caring for lots of people, sometimes young people, sometimes your parents, sometimes the neighbor next door, but you're caring for everyone else because in general, your health is pretty good. And so you take that to mean I should be doing for others. And it is important as a community for us to come together, but you also have to take time for yourself and try not to do so many commitments. We don't say no. There's that ongoing guilt that we talked about. But what's interesting is even for Michelle Obama, you know, she recently came out and said that she was going through this low-grade depression as well, which I think normalized it for a lot of people, especially during the pandemic, to talk about their feelings, to talk about they were lost, to talk about the lack of motivation that they were experiencing. And so it becomes this reminder of nobody's a superwoman, nobody's a superman. And when you hold yourself to those standards, even because you think other people are doing it, then you're doing yourself a disservice. And so you just have to remember to define your own boundaries and what you're able to do at any specific time. So in terms of talking about minority populations, I think that one of the things that came through is that there's a quote that I find very helpful. And it's that we must understand and be aware of the impact of history, identity, meaning of racial differences and experiences of discrimination and isolation on mental health. And the reason that's there is because when you take everything from, you know, there's a lot of historical data that tries to understand mental health in Black communities and why, you know, sometimes people are less likely to seek help. Why, you know, is it from historical times where there was fear that, you know, unmasking or identifying mental health meant that families would be pulled apart. There's many reasons why historically we think that people in African-American communities are less willing to ask for assistance, less willing to say, hey, something's wrong here. And until we identify all of those things, then we may not fully understand the limitations and the barriers to people actually being willing and ready to ask for help. In addition to that, there's a lot of things that are going on right now. So we've got, you know, displacement due to many different things, redevelopment, gentrification. We have low income families often having to relocate. We've got these networks, these social networks, especially during COVID, that are starting to change as well. And where is your support network? Who can you go to? The schools are closed. And so does that mean that even sometimes parents that usually will go to the school or talk to the teacher, their support system has been changed a little bit. In addition, we've looked at, there's a lot of publications that have looked at the mental health implications of things now like COVID, but even before that, like Hurricane Katrina and how that had to displace people and what that meant, Hurricane Maria and what happened with, even getting aid to Puerto Rico. There's just so many different issues that have come out of these natural disasters that still have to be addressed to really understand how people cope with stressors. And the roadblocks that we've talked about, the roadblocks to treatment. So culture, values, the belief system, the stigma, looking at cultural norms and expectations. We have to also consider that there's limited minority providers. I was able to work with some of my colleagues at Johns Hopkins to look even in the Department of Psychiatry at how many providers of color there are. And there are not very many. And so what we're seeing is that if there is this push to identify with the person providing your care And that can be many different things. Certainly that can be race, as it's one of the first things that we see, but it could be gender. It could be sexual identity. It could be cultural beliefs. It could be political beliefs, although, that's not really supposed to be one thing that we talk about as the provider. But there could be a lot of different reasons why you want to seek someone who looks like you or shares some of those beliefs. And sometimes that's just not readily available. And so even in training programs, in psychiatry residency programs, there's a push now to continue to encourage diversity so that we can provide additional support to our communities. Similarly, even for people that don't identify as minorities, what we know is that training with a more diverse population of doctors, it'll make you a better doctor anyway to provide care for those that come through the door. And we talked a lot about kind of these past historical experiments. I think most people have heard of the Tuskegee experiment. A lot of people have heard of Henrietta Lacks, which is actually becoming an issue again now with the COVID vaccine. And there are a lot of minority populations that are very hesitant once a vaccine does become readily available. And so we have to be able to understand our history in order to really have an open discussion about people moving forward, how they'll kind of provide and seek not only care in psychiatry or mental health, but really for all realms of their health. I want to just talk briefly about treatments. I won't go into a lot of detail, but the thing to remember is that one of the reasons I'm here and that I'm talking to you about mental health is because it is absolutely a medical illness. And when people are able to accept that, they're more likely to really pursue treatment. And so similar to the way that I describe it is it's really, really hard when someone's here for their first diagnosis, because the way I often describe it is, listen, if you are, in my office and I'm trying to diagnose high blood pressure, and what I'm going to do is I'm going to put a cuff on your arm, I'm going to get a number, and I'm going to be able to show you that number, and I'm going to be able to say, see, above this number, you have high blood pressure. Below this number, you may have low blood pressure, and there's interventions for both. Mental health is not like that. And so the only way we get to really diagnostic and treatment recommendations is to have a discussion, an open and honest discussion about your history, about your family, about how you're feeling now, all of those things. And if it reaches the level of really illness, of a depressive episode, we may talk about antidepressants. We may talk about starting medication, because this is not something, once it reaches that level, that you can will away. It's not something that you're doing wrong because it doesn't go away. And so just like having some sort of infection that requires antibiotics, this is an illness that may require medications to get you better. So that can go for depression, that can go for anxiety. We utilize what's called mood stabilizers for bipolar disorders, which means you can have depressive episodes as well as manic or hypomanic episodes. But sometimes all that's needed is therapy. We talked a little bit about, specific phobias. Let's talk about public speaking. Let's talk about speaking on Zoom where you can't see anybody nodding their head. You can't make eye contact with people. So sometimes there can be specific things that will cause a lot of stress. And that doesn't mean that it reaches that level of needing medication, but it may mean that you need to talk to somebody and you need to have a plan for how you're going to cope with these things that are causing you anxiety and stress. And then in a broader sense, if medications fail, there are other things that are still very frequently utilized by psychiatrists, including electroconvulsive therapy, transcranial magnetic stimulation, as two of the interventions that could be highlighted. Spirituality, I'll take a minute for. It doesn't matter if you are religious or not. But what we are seeing is that sometimes someone will say, well, I'm not religious, I'm spiritual. But whatever it is that is the key for what you need, if there is something different, if there is something else that you need to seek to kind of feel fulfilled, then you want to still be able to highlight that. And so what that means is sitting down and really understanding, when do you feel good? What kinds of things make you feel better? What kinds of things do you lean on? And that's going to be different for everyone. But what we do see a lot of times is that if there is religion, if there is spirituality in that component, we do want to integrate that. And if there's not, then there's other therapeutic interventions that we can use. And aside from the religious aspects, aside from the spiritual aspects of that. And I think this is my last slide. And I just wanted to talk about strategies to improve your own mental health. And just remember, when things get to be too much, please ask for help. And I'm going to reserve the next few minutes so JHSAP can talk to you about ways that you can manage that. You have to sleep. You have to sleep. You have to sleep. So the other thing is, please make sure that you're getting the right amount of rest. Diet and exercise are also important things. Sometimes saying no, if you really can't fit things into your day, or if you don't have the mental capacity to do them, it is okay to say no sometimes. Remember that. And then you have family, you have friends, you have primary care doctors. I know some people that are still youngish may still rely on their pediatrician. Just reach out to somebody, because more people than you realize have experience with mental health issues and can probably point you in the right direction. And that's it. I can take questions, or we can wait until JHSAP is over. Now, this is a slide that I used specifically when I was doing a talk for kind of women's mental health. And so they have kind of women on the left side and men on the right side. But the point is, at some point, we all feel like we're on that left side. It can be you're a working student. It can be that you're trying to take care of your family. It can be that you're not able to, sit in class, and you do so much better sitting in class. But whatever those hurdles are, they're on this side. Just remember that at some point we all feel like that. You just have to figure out how to get some of those things out of your way, or how to go around them. And that's what the medications or therapy or talking to a family member or friend are for. So I think that's all I had. And I think we're going to go straight to JHSAP, and then we can take questions at the end.
Hi, everyone. Can we have, okay, Amanda's coming on too. Thank you, Theo and Dr. Richards, for initiating this conversation and for inviting JHSAP to be a part of it. It's really important, and I'm glad we could be here. So as Theo mentioned earlier, I'm Mary Vincitor. I direct the Johns Hopkins Student Assistance Program. And with me is Amanda.
Hi, everyone. Sorry.
Who is a clinician, and typically when we're in person is in DC. So some of you may have met her before. We have had a lot of recent hiring changes, so we're growing, some structural reorganization, and now we have 2 full-time clinicians in DC. So hopefully when, if anybody wants to meet those folks, get an opportunity to do so online or in person when we resume in-person activities. So I'm going to go ahead and share my screen. Can everybody see that? Okay. So the Johns Hopkins Student Assistance Program is a program that's been around for a long time to help support students. And we're part of the larger student health and well-being portfolio. And there's been a ton of investment in the last few years from the student affairs perspective, through the president's office, to ensure that we're having enough resources and the appropriate resources for students. And we're looking at it from not only a student perspective, but what are the differences in the needs of students who are on the undergraduate level and the graduate levels, those in DC, those who are overseas. So really looking at that. And then more recently, even, really having to look at what we've done and what we still need to do in regards to the typically marginalized students, the underrepresented populations that we have within our schools at Johns Hopkins, and really investing in that. So I'm happy that we're having these conversations and looking forward to even feedback from folks about what else we need, what are the other things we need to be doing moving forward. But to talk about well-being first and wellness, really to build off of what Dr. Richard has shared, is I want to talk about why it is important in the first place. And we know that our overall well-being is critical to our success, whatever that is for you. It's a very individual sort of goal and set of expectations for yourself. both personally and professionally. And so our well-being really is to be considered in that larger picture. We know graduate school is very stressful. And for some folks, it's more stressful at certain times. Folks who are new to the programs may be ramping up and transitioning to a new culture. We also have folks who are in the last stretch of their programs, and they may be finding that particularly stressful. We know that now, baseline, graduate school is stressful, but then we have, as Dr. Richards talked about, the pandemic, which is causing significant impacts to our ability to normalize our days, to regulate our schedules, to take care of ourselves, and is causing a lot of isolation. And then racially targeted violence and an increase in the consciousness around systemic racism is bringing a whole new set of energies to both the individual and the collective. While it's always been there, we're experiencing it in different ways as a community and individually. And those are all bringing new levels of stress to our day-to-day lives. And one of the things that often Hopkins students don't want to acknowledge is that it's okay sometimes to not be okay. And it's definitely okay to ask for help. And I think Dr. Richards emphasized that as well in her presentation. It's really asking you to consider, what is it for you that well-being means? And as we're talking about the resources that are available to you, I'd like you to think about, what does well-being mean to you? And what are the components of that? What's going to really help you thrive? And what are the ways that you would know if you're not doing as well as you hope? How do you assess your level of stress? Dr. Richards talked about some of the different symptomology, and sometimes it's behavioral. She talked about an increase in substance use. Sometimes it's emotional, where we're feeling less regulated. It could be intellectual or cognitive, where we're just not functioning in the way that we typically would expect to. And then there's always the emotional components, and I think I missed physical symptoms, where we might have headaches or back pain, insomnia. So really, what is it for you that shows up when you're stressed? And then we're going to talk about, what do we do about it? One of the things that I really want to stress during a time like COVID and the various things that are impacting us in the United States and throughout the world is this little chart about performance over time. I saw it last night and I added it to the presentation. Doing your best might look different each day. 100% may not be what our goal is right now. Maybe doing the best that we can and recognizing and accepting that it's going to look different every day. And that we need to set realistic schedules for ourselves and try to stick to those and recognize that we might always not meet the mark. Dr. Richards also talked about different types of self-care. These are all super important. I've included, as she mentioned, getting together with a primary care doctor or a specialist and making an appointment with JHSAP, with one of our clinicians. It's just a good way to check in. We really do want to look at this on a continuum that JHSAP addresses support for folks from challenges of everyday living to navigating the Johns Hopkins system, the new environments, to major mental health issues like depression and anxiety, suicidality, where we're really helping somebody wherever they are on that continuum. And we'd like to see you earlier in the continuum than later. So reaching out when you think things aren't going so great, just to check in and introduce yourself to us and work with somebody is a great first start.
And I just want to make a note on that. I've had some students sort of be apologetic during the intake of, I'm sorry for reaching out. I know whatever's going on for me, it's not a big deal. Or, I know you probably see people who are worse off. And, and I say to that, thank you for making that appointment and coming in. And, I don't like to compare students to each other. Everybody has their own circumstances, but just kind of echoing what Mary said, it's just so much, it's going to save you a lot of pain and suffering to come in early so that we can create a plan and help you feel better sooner rather than later. So there's no threshold of you have to be doing, like poorly to some degree in order to take advantage of JHSAP. I just wanted to put that out there.
And I think, again, comparing ourselves to other people is not the best mechanism for our self-care and resiliency. So when you're listening to all the things that people are doing, like I know people who, were starting to learn how to cook, or, and then they running 5 miles a day and meditating every night, like that may work for them. You need to find out what works for you. Find one thing, figure it out during this time of remote living and learning, and just go ahead and commit to something that works for you. It might not work for everyone. You need to focus on what works for you. So I want to talk about JHSAP. So we do for confidential and free talk to our clients about. You
This
decide
meeting is being
what
recorded.
you want to talk about and what your needs are in relation to your clinician. And I saw a question in the chat that how do you identify is a good find someone who's not just going to push medicine. One of the things that we're really good at is talking about your needs and identifying options and making that plan, as Amanda said. We really have no agenda for you except to find out more about you, get to know you, and help you navigate your own life questions, but also the community that we're in, both from Johns Hopkins Resources, Student Affairs, if you're an international student, the Office of International Services. We really do have a good connection within the community, both as well as outside in the greater DC, Baltimore area. We know a lot of providers, and we can help people get connected to someone who is a good match for them, even if it's not us. So sometimes it's us. We have great clinicians. They're really smart and they're really committed. And sometimes it's not the best match. So we find that for that help. It's a collaborative approach. And as I said, we determine the best fit and we work forward to try to get something that works for the student. I want to let you know that, again, Johns Hopkins has invested a lot in wellness resources over the last few years. This website is goodtoknowwellness.jhu.edu. There's a lot of resources, including events that are available for you to stay engaged, particularly at this time of remote learning. You can look for resources here. If there's a crisis situation, you can access crisis information, contacts. It's all sort of a one-stop shop. I want to highlight some specific programming that we've had to help people stay connected in recent months. The University Health Services Wellness Program has done a lot, and there's their link. They've done pet therapy and daily meditations with very, very talented and committed meditations teachers. We've had some students sign up to do food prep as a mechanism for connecting and de-stressing and being healthy. And then the Cooley Center, which is the campus health center, fitness center on the East Baltimore campus, is doing virtual workouts. So you can access all of these yourself. You don't have to pre-register. You just go in and sign up. So if you want to take a screenshot or a picture of that, these are good resources to start with. And then I wanted to highlight one particular, since we're talking about the experiences of Black, Indigenous, and people of color, and the racial violence and targeted violent activity that we've been experiencing or hearing so much more about and activating around. We have the Home and Counseling Center is offering an open group on Wednesdays, every other Wednesday. It started last week. So if you're interested, you can check out the Home and Counseling Center's site. They have a bunch of different kinds of groups, but this one I thought was particularly helpful or interesting to this presentation. And you can talk to the two There's 2 coordinators, and they're great. They can help you sign up and be welcomed in this group moving forward. I want to talk about a few other online resources that the institution is offering. We purchased a subscription to Silver Cloud, which is an online cognitive behavioral platform to look at depression, anxiety, and stress and resilience on your own time and your own pace. That's available. We'll send you, you'll see the presentation, so you'll be able to follow the link. But this is one of the products that we've been using and students have been accessing and like. Another is the telehealth relationship we've established with Timely MD. They have been, this is primarily because we have so many students who are now out of state, out of the district, and we need to have providers licensed in the areas that they are located. So for the person who asked the question earlier, this is one option as well, is to give a call to Timely MD and work with them. You can identify, you can talk to them 24/7. Or you can do scheduled counseling. These are with people who you see their profile on the site, and you can identify someone who looks and sounds like someone who you think you would have a good connection with, and you can work with them on an ongoing basis. We are also offering psychiatry through them now, an assessment and medication management if that's appropriate, and you would just need to let JHSAP know that this is something that you'd be interested in. To get started, the link is at the bottom, and you use the service key JHU 2020. And I know I'm running low on time, so I'm going to just go through. Hopefully most of you have seen the COM app. This has been really popular with students, staff, and faculty. You just enter with your JET ID, and you get the free premium through Johns Hopkins. And it's meditation, it's sleep stories, it's master classes. There's a whole bunch in there that's really just enjoyable and relaxing for folks. I want to add that.
Can I just say one thing about the COM app? Because some people have had some trouble. Make sure that you activate it through that link and not through the app itself first, because you want to get the free content and you have to do it through that link first.
So the COM app is pretty general. There's a few apps that we were aware of that are more specifically supportive of the Black, Indigenous, and people of color community. And so Elevate, Liberate, and Minds of the Culture, great apps doing some of the same things. Lots of, some videos, some inspirational quotes and meditations, really, really great resources. So that's available to you as well. What I want to say just in closing, and then we'll have Q&A, is it's okay to ask for help. It's important that you ask someone that you think you can trust, or you're developing a trusting relationship with, or well. Could be someone in your faith community, could be someone in your cohort, an advisor, staff member, faculty. Just reach out. JHSAP is one resource, and I gave you a bunch of others. But we're 24/7 and just one way to come in. And you don't owe us anything, just to check in if you want support, and we'll be there to talk you through the options, because ultimately we're all going to continue to have ups and downs in the coming months and year. There's no two ways about it. Life is going to be complicated, and grad school is going to be tough, but it's okay sometimes not to be okay and to ask for the help. So if nothing else, please remember we're here. Take a video, screenshot of this page and give us a call. Let us know if you have questions. Check out the different websites, and we're happy to help you navigate. Thank you.
Do you want me to try to take a crack at some of these questions?
The recording has stopped.
Okay. So I was wondering if Dr. Richards wanted to weigh in on the first question about finding resources, but if there was anything else you wanted to add to that.
I think Mary, that was good advice. I mean, it's tough. And so working with someone that you do trust will be the first step. There's a website that many people use also called Psychology Today, and that has psychologists and psychiatrists in it. And the reason I highlight it is because it does say what insurance they take. It does say what their philosophy is about participating in therapy. But the bigger thing is that you really, what I encourage everyone to do is to give it about 4 to 6 visits. Because the first visit, everyone's nervous. Is this going to work? Is this a good fit? And so you're not going to get through a lot, but really by about the 4th time, the 5th time, you'll understand, are you feeling better when you leave? Are you feeling like you really can share the things that you were hesitant to share on day 1? But after day 1, it wouldn't surprise me if you're not sure about that therapeutic interaction yet, but give it some time and give the relationship, a chance to build.
It's usually not too comfortable to go in and share a lot of personal information. And sometimes we ask questions in the first 1 or 2 sessions that people don't necessarily want to answer. So we're trained to give you time and space to develop that relationship. And I always encourage people that if you're not quite sure why the person's asking you the questions or if it's working, the rapport is building or not, to just ask as a consumer again of this service, say, is this typical? How is this going? Where are we going? Ask what the goals are. If you're unsure, you should be encouraged to communicate openly with your provider.
And if you have connected with JHSAP while you're in the search for a provider, or if we've referred you out, we can help you with this process. A lot of times I'll have students, we'll have another session set up just to kind of bridge the gap while you're getting connected with the provider. And sometimes students will come back and say, well, this happened in this session. Is that normal? This and that. And I can sort of help coach around, well, how do you get clarification? How can you maybe work out some of these things? Or, every once in a while, it's not very common. Once in a while, something maybe happens that I'm like, you know what, maybe you should find another person. I mean, we can definitely kind of help you with that process if it feels too scary to go it alone, or if we've been the ones that have encouraged you to seek outpatient therapy or psychiatry, we're not gonna just drop you. We want to make sure that you get connected with somebody who's a good fit.
And I think the other thing is you may have to do a little bit of education. Now, people will say, I'm not going to a therapist that I have to teach them something. Mm-hmm. But if you're with someone, maybe even from the same race or culture, but there may be a need for education. I don't like it, or my family didn't say X, or, typically African-Americans don't like it when you may have to explain why that creates a certain emotion in you, but the therapist will still be able to help you work through that. Now, I'm not all encompassing, things related to the African-American community. There'll be things that I don't know. If I have someone of Jewish faith, for example, I do need to understand their standards. I need to understand their culture. I need to understand the things that are important to them, but I am willing to learn and listen and still try to work through it with them.
I think it's important too, if you are getting the feeling that the person is asking you to educate them, that's different. If the therapist is saying to you, tell me how that affects you. What are your thoughts about that? I want to understand how you relate to that. You grew up in that way, or in that community, you grew up with that understanding. How does that affect you? As opposed to somebody saying to you, tell me what the experiences of that population are.
Yes.
You don't want to be teaching this person. And we have heard stories about that in the past. And I've really, so really looking out for your own interests is important. But again, giving it a chance, giving the person a chance. One of the things we know about all caregivers right now is that they are also stressed themselves. So we want to be patient, but not accept things that don't feel good for us. I'm going to skip to, because we're running out of time. An appointment with JHSAP, does it stay in our records? JHSAP is required to maintain records on who we meet just for legal and safety purposes, but those records are JHSAP's alone. We don't share them with anyone. It's our own internal system. So there's only a few people who have access to those records, and we keep those for 7 years. The school never sees them. If we need to share records, it's only by the request of the student. And then the last one, I think, will open up to everybody. But yes, there's a lot of folks looking for jobs that have security clearance requirements. And one of the things about our program, and then I'll pass it on to others, is that we are not technically considered a medical provider, a medical provider in the sense from mental health. So we encourage students to share if they've had support through counseling at school, but that it's not a medical care. And so being really conscientious of how the questions are written, we can kind of contextualize it as we don't diagnose and we don't treat. So we are a support system within the school versus a counseling program or a diagnostic medical provider. But I'll have Dr. Richards, do you want to add to that?
Sure. So this is a common misconception that I actually explained to a patient yesterday, even who has a security clearance and came to see me. Typically speaking, seeing a psychiatrist or a therapist will not keep you from getting a clearance. Lying about it will. So if you see somebody, you need to be able to say, I saw someone for depression. I saw someone for alcohol use disorder. They may ask me to sign something saying that I don't have any concerns about your mental health. That would mean that you shouldn't have a clearance. Find out you saw somebody and you say you didn't, that's when people get into trouble. And I can guarantee you that I have seen plenty of people that have had security clearances and have been able to maintain them after they saw me.
And I'll add that because, as Mary mentioned, that we're not considered to be treatment providers, we see very few, or I can say from my personal experience, and I was the sole clinician in DC for many of my 6 years. So I think I've probably interacted the most with students who are either have or are seeking security clearances, because the majority of the students are in SAIS. I can say I think I've been contacted twice in all of those years. And the way the questions were phrased, I couldn't actually answer them because we're not treatment providers. These weren't questions that we could answer at all. I think one time maybe we gave the student like a summary of their records and they could do what they wanted with it. But this very rarely comes up. And so considering the, hundreds of students I've seen and how rarely it comes up, I think I wouldn't put a lot of concern into it in terms of JHSAP in particular.
I just wanted to jump in real quickly, and we're basically at time, but I wanted to ask Dr. Richards and also Mary and Amanda, since we are at an IR program, we do have a lot of international students. Can you just kind of real quickly say what are some of the best strategies for international students that are kind of facing all of these anxieties, but also trying to cope with cultural change and cultural shock? If you can just kind of just explain some of those strategies as well.
In the interest of time, I'll just highlight one, which is find your network. And that network might be, that network's going to be different depending on what you like. It's hard now for pickup basketball games. It's hard now, for book clubs, but a lot of these things are becoming more virtual and you're not alone. Everybody is looking for that group, that network, that support system. So you have to, it's almost easier to put yourself out now. If people had more social issues before, we'd say, oh, you got to go to this thing and you got to make sure you ask a question. You have to, but now it's really going online in a safe space and finding out who shares some of those interests.
And maybe I'll just add briefly, I'd say balance, look for things that feel familiar and balance that also with, trying to embrace the culture. I've had some students where they want to embrace English so fully that, they're trying to avoid speaking in maybe the first language, for example. And that can be really exhausting potentially. And sometimes it's really nice to find others who might share your first language or share a meal of familiar ingredients, etc. And then balancing that with finding your local networks, embracing, practicing English, even if it's not your first language, or, other aspects of the local culture. So sort of balancing those two things.
Okay. Mary, any last points?
I would say talk to Theo, and we will partner together to see if we one of the things we've done recently is facilitated discussions. So just having people get together, and JHSAP can be a part of that or can help sort of conceptualize that. We can jump in. In one recently, we jumped in at the beginning and we jumped in at the end for just questions, but the group got to talk. And so we just want to be creative. It is about being creative right now. It's always been about being creative, but it's even more so about being creative.
Thank you so much. Want to thank Dr. Richards. I want to thank Amanda, Mary, so much for the conversation. I think it's extremely important. I hope that the students that were watching got something out of this conversation. I know I did. So much valuable information that was presented today. Hopefully you take advantage of all of the resources that JHSAP mentioned, and there was a lot. So we know that there is a lot of access, resources to access for students. Want to thank SAIS Diversity Council again, to Bahar and to Dean Rice for helping us and partnering with us on this event during this week, this very important diversity week. We do have 2 events tomorrow, so I hope you will tune into those. And I want to thank you again for joining us. Take care.
Everyone.
Thanks, Theo. See you guys later. Bye.
Bye.